Okay, so again, so we saw that the course where you from an ivory tower working with studying brain science, figuring out very, very sophisticated but quite theoretical things might benefit from the real life situations that we confront in our hospital when we go into the brain, remove parts of the brain, remove tumors which infiltrate into the brain and try to make as little damage as possible. To this end, we designed a course which has 5 days. On the first day, that's today, of course, we introduce you in a kind of crash course into neurosurgery. We'll start with the biology, and we end up showing you the simple neurosurgical operation. And then we would like to make a little experiment and bring you one of the models that we use to teach residents, removing brain tumors, having cow brains with the brain tumor model. And you have the opportunity to touch the brain and to see the problem that we confront. It's very simple, and hopefully the brains are still good. They started to smell a little bit, but that's life. And then on the second day, we would like to introduce you into the functional neuroanatomy. Now, some of you might be very much sophisticated, might have very sophisticated knowledge of particular parts of the neuroanatomy, depending on what you're studying. But we will like to show you our perception of anatomy and functional anatomy in a way that we show you very simple things, but they work in our hands. And what we also would like to do in this course tomorrow is that we show you how we map and monitor central nervous system functions. Because that is, as you will see, the most important part of this lecture series, that we try to preserve functionality. And then on the third day, we will come to the center point. That's where we meet, awake surgery, when we try to preserve new functions on the focus of language. Now, and that's the thing that makes us so excited about collaboration with Professor Budzinski, is that he has, as a linguist, quite a different perception of language as we as neurosurgeons have. So when we started to meet him, language for us was, patient was counting 1, 2, 3, 4, 5, and was able to name pictures during surgery. And when Josef entered our life, he said, this is not language, this is motor functions. And at that day, we will have a lecture of Josef explaining what language is. And on the fourth day, we will take you into the decision-making process of a neurosurgical approach, integrating all that you have seen before, reading the MRI scan, from the MRI scan defining the potential danger points, and of course planning the mapping. When we are planning the mapping, Josef will enter again and show you how he improved with the map that he designed our language test. And on the last day, on Thursday, we put it all together by showing you full-length neurosurgical approach to a patient with language mapping. Is that okay? I think so. Now, I would like to give the word to Marion. That's a program that we have today, and she will start off with the basics about infiltrating brain tumors.
I should send it. So also from my side, thank you very much for the invitation. And this is the program for today, and we designed it as a discussion, but hopefully not only between us two. It can be a conversation between all of us. So you're more than welcome to ask questions. So first, basics about infiltrating brain tumors. So what it is all about? What are we doing?
Get everybody here, because I'm personally deaf, so I'm very sensitive to this. So maybe we'll put up
a microphone.
Yeah.
Do I need if it's not loud enough or too fast?
I
Or
think we should do this. It's like just putting this on, and that's it. Yeah. One here. I think we can probably This is probably
better. I think we could just probably leave it here, so you don't have to hold it all the time.
Okay, is it better now? Do you hear me?
Yeah.
Better?
For recording, it's better that she wears this.
Sorry?
For the recording.
Yeah, we will change it.
The recording, she has to stand there because there's another microphone, and that's the point. So can you hear any better now?
So I'm not moving, I'm just standing here. Try to speak as loud as I can, and I hope you can hear me now better. So of course there are a lot of different brain tumors, but it's not working as well. So, but this course is about infiltrating brain tumors. So there are low-grade tumors, high-grade tumors, and of course metastasis. Metastasis is actually one of the most important illnesses because it's quite an amount of illnesses. But we concentrate on low-grade and high-grade gliomas. And this is an example in pictures on MRI scans. How do they look like? And what do I mean by infiltrating, or the differentiation between infiltrating and not infiltrating tumors? So these are examples of not infiltrating tumors. It's a meningioma, pituitary tumors, or neurinomas. And these are tumors that have a quite clear margin. So you can resect them completely and you can cure the patient by the operation. But you can't do this with infiltrating tumors. And that is why we call them malignant. So they are slow growing or fast growing, but it doesn't matter, they are malignant because we can't remove them completely. And I always try to explain to our patients, they are growing like roots. You can see the most important part of the root, but you can't see this little small angles keeping and fixing in the brain. So again, we talk about low-grade gliomas and high-grade gliomas, and they generate from astrocytes. And yes, you've got a question already. Michael will try to answer it.
Okay.
When you say cure the patient completely, do you mean it in cognitive sense, or just that it's not a life-risking tumor?
It's a very good.
Complete resection, do you mean? Sorry, I didn't really get your...
Yeah, when we ask the patient, we tell the patient that we do a complete resection. What does it really mean?
Well, I'm not allowed to say that with infiltrating tumors. I can say with a meningioma patient, I will completely resect, and then I cure the patient because on the MRI scans there won't be a tumor anymore, and they won't grow any tumor anymore after a few days or of years. But if it's an infiltrating tumor, I can remove part of the tumor that is visible on MRI scan, but you never can remove the whole tumor. There will be residual tumor cells in the brain, and this is why they're infiltrating, why we call them infiltrating brain tumors.
So when you say cure, it's just normal tumor, but we can have a cognitive decline afterwards.
Say again.
So after we do the operation, you have removed the entire, let's say we remove the entire tumor. So the patient is tumor-free in this point. When you say cure, ask about the definition about it.
Yeah, but that's actually the point that Marion wanted to make, that we have brain tumors which can be removed completely. Tumors out. But the point of this course is, and we will explain it later, is that with the kind of tumors that we are talking here, a cure is almost impossible because they have this infiltration zone. And the problem of the infiltration zone will be explained by Marion now.
So the resection in infiltrating tumors is a very important part of the therapy, but only the first part of the therapy. At the last point for today, we will also talk about adjuvant treatments, so radiotherapy, chemotherapy, and this will be needed in infiltrating tumors, but not in tumors like a meningioma, where you've got margins, where you can resect the tumor and cure the patient. In these tumors, it's not possible. So they generate from glia cells, but actually the reason why it's becoming a glioma, we still don't know. And this is taken from an older overview where you can see that it all grows together. For example, you've got astrocytomas, oligodendrogliomas, it's the original cell, and then we differentiate in VHO grade 2, 3, 4. And the higher the grade, this is from former times, the more aggressive, the more rapid growth the tumor was. So we've got high-grade tumors because they are more aggressive and they grow quite fast. So it's a WHO grade 3 and 4. And low-grade gliomas, which are growing more slowly. But still, both are infiltrating tumors and both are malignant tumors. So we cannot tell our patient it's a benign tumor, after surgery everything will be fine. And this is a quite older overview, just for example showing that it's a slow-growing tumor, high-growing tumor, and there can be a malignant transformation. So if you're diagnosed with a slow-growing tumor, the tumor can change. And the tumor will change. It's just a question of time when the tumor will become more aggressive. In 2021, the neuropathological classification changed a lot. So in former times, we just looked at the cells. So how do they look like? Do they have necrosis? What vessels look like? Now we know, and just, of course, you don't have to remember all that. It's just an example of how we now diagnose the tumor. So now it's an integrated diagnosis because in the last years we learned that the molecular biology of the tumor is getting more and more important. So it's not that important how the cell looks like. It's just one picture of the cell. It's more important if it's IDH1 mutation or IP19Q deletion. So the molecular basic of the tumor is getting more and more important, resulting now in the classification and the name of the tumor. So how do we call it? And you can see it on the bottom line. And you can see at the end of the day that these integrated diagnoses will lead to the classification of the adjuvant therapy. So this decides now if there's an adjuvant therapy needed or not.
Maybe I'm getting a little bit ahead of the game, but my question now is, what is your role in the diagnosis? Because most of the diagnosis is based on lab work, I would imagine. Mm-hmm. Do you guys have a role, a formal role in the diagnosis?
Not really in the diagnosis, because the diagnosis can be done with very small tissue. Our job is the first step of the therapy, because we also learned in the last years that if we can remove as much as possible, still there are remaining cells, but if we can remove as much as possible, we can help our patient and prolong survival. So we are not only making the diagnosis by putting tumor tissue out and bringing it to the neuropathologist, we are the first step of the therapy as well.
So the decision on the grade of the tumor is never done before surgery? Never?
No, we got MRI scans, I will show you later, and there you got a suspected diagnosis of a tumor. So a low-grade glioma got a specific picture on MRI scan. A glioblastoma, this is a rapid-growing tumor, got a specific picture. But actually, we cannot be sure. So we suspect a special tumor, but we cannot sure because I can't see an IDH mutation on the MRI scan. So, for example, from the picture, it can look like a slow-growing tumor, and the neuropathologist tells me, well, but it's got an IDH wild-type mutation, so this tumor will change very rapidly into a high-grade glioma, and then we have to treat it more aggressive than we thought from the MRI scans.
And there are no tests like proxy, like from lumbar puncture, like CSF and things like
Not
that?
Not yet. And the first step of the therapy, independent if it's slow-growing tumor or a rapid-growing tumor or even a metastasis in the brain, the first most important step, or one of the most important steps, is an aggressive resection. So even if I know it preoperatively, if it's low grade or high grade by the diagnosis, my decision, should I resect it, and the way how should I resect it, it's made by functional systems. So is it possible to resect it as aggressive as I want?
But you asked if there's any way to understand the molecular biology of the tumor just by MRI scan. Is any one of you involved in imaging? MRI imaging? The first step that we see here, the ADH1 mutation, can be detected in MRI scan. That's starting now. And this will be very interesting to go into MRI scans looking at the molecular genetics of the tumor, which is starting now. And that, of course, as you see, is a very big step in the decision-making process, because if you have an ADH mutant tumor, it is completely different treated than the ADH wild type. And if you would see that in the MRI scan before, and not only seeing, as Marion will be explained later, the contrast enhancement as a decision-making process, things become much more easier for us.
So again, the picture of two infiltrating lesions, the low-grade and the high-grade gliomas. And this is again a picture trying to explain what we mean with infiltration zone. So in the middle, you can see the necrotic part of the tumor, where the tumor in a high-grade glioma and a rapid-growing glioma is growing so fast that you've got a necrosis tissue in the middle. And then you've got a more solid tumor surrounding, and after that the infiltration zone comes, where you've got tumor cells next to functional cells. So the minimum of the resection is that we try to respect that border, but of course now, if it's possible, we try to go beyond. And this is even more difficult with low-grade gliomas because of the slow spreading. They haven't got a necrosis zone, they are just mixed. So there you've got functional tissue and tumor cells right next to each other. And it's not only a local diagnosis. So if you got a brain tumor, it's an illness of the complete brain, because the tumor can infiltrate along the fiber tracts. So the tumor is growing, and it's through the whole brain, and it can grow here, but it can also grow along the fibers and pop out in a different place. So it's a systemic disease of the brain. Okay, so now the big question is, as I already told you, it's not possible to remove the complete tumor. There will always be residual cells. So what's the evidence? Why am I so fond to say, yes, we are the first and one of the most important steps of the therapy?
Other questions to that point? So the big point that you should take away from this first part is that these brain tumors that we're talking about have this infiltration zone where we have an intermingling of these extremely dangerous cells with functionality. And your question, can you remove the tumors completely, is already answered at that point. Yeah, we can take it out, but then we take out functionality. And as you've seen in the last, is this working? If you've seen this, of course we can remove this. Can I have the pointer? Of course we can remove this, but then we have still to mess up with this stuff here and take it into account for the therapy, because it's like exponentially growing cells and migrative cells. So the question about curing this kind of tumors has a big question mark, and therefore we need to ask the big question, does our job make sense? Why do we resect brain tumors when we already lost the case on the biological level? Now that was a reason why brain tumors, sorry, question? So, sorry?
In what you presented,
Yeah.
the glioma.
Yeah.
So it's just the glia cells that are...
Yeah, the tumor that we're talking about are arising from glia cells, astrocytes and oligodendrocytes, not from the neurons. There are tumors from the neurons, but they are very, very rare. This is a glia cells. basically the connective tissue of the brain. So, of course, evidence for brain tumor surgery is interesting because but from the biological point of view, it does not really make sense. And we divided it into evidence for high-grade gliomas and low-grade gliomas. Now, typical glioblastoma. And this is one of the pivotal papers, fortunately coming from Düsseldorf, showing that you're familiar with Kaplan-Meier curves, I suppose? Are you familiar with that? Shall I just explain that? Who understands this diagram?
Tell us what you have.
Okay, you know what you know. Okay, what is here is that we start with a population of 100% patients. Okay, and then we have a timeline, and we have a percentage. Now, what you see is that the number of patients is declining, and every little mark here is a dead patient. Now, you see a difference between the survival in both patients' populations. This is quite substantial. It's quite substantial, and you see that in this curve, obviously, even after long observation time, not all of the patients are dead. Please.
So what is the level to evidence here mean?
Sorry?
What is the level to evidence here mean?
The level to evidence is coming from the observation or from the situation that we divided, that both groups are adjusted for bias. They're adjusted for bias so that the only difference between both groups, and that's now the important point, is the extent of resection. So in this group here, you find all the patients who have a gross total resection. That is not a complete resection, but it's a resection where we do see no contrast enhancement residual tumor. Okay? So as this group have only the difference between resected or not resected, good resection or no good resection, this is an evidence which supports the role of surgery. So with this curve, we can say, on a certain level of evidence, that if we remove this part of the tumor, the patient will have a better survival. And most importantly, a certain group of patients will survive for a very long time.
Can you explain that timeline for years?
The timeline is not years and months. So we still talk about a very limited survival. And the survival advantage is here something around. So when we take 50%, you see that something around difference between 14 and 18 months. But for neuro-oncological patients, for patients with malignant brain tumors, this was kind of a game changer. We didn't see that before. Now, very important is that from this study we learned, as you can see here in the visualization, that we have to go for a resection like this, and that this is not acceptable. Why? Because when we did further analysis of the cases, we saw that as much as 1.5 cubic centimeters of residual tumors decreased the life expectancy again. So our job is to get the tumor out as completely as possible. Again, your question was a very good question. This is not a biological complete resection. This is a resection where in the post-operative MRI, we don't see any more tumor. Okay? Gross total resection. Now for the low-grade gliomas, please.
Is that possible, or is there some selection bias in the beginning? Because the one you can do the surgery actually is the one you can do the surgery. Probably the bias that you choose the actually more mild patient compared to the control. Because if you control the survival rate of the people who did not get surgery and the people who get surgery, actually the people who get surgery are more biased, probably they can get surgery because it's
That's a fundamental bias in the selection for surgery, but we are talking about the surgical population. These people all have surgery. And we adjusted for bias by having a huge population, and we saw that we tried when the study was done to select to have a comparable population. Okay, so in the end, the median age of the patient had a good resection, the Kanofsky performance score, which is a clinical performance of the patients, and basically also the localization of the tumors were the same. Okay? We divided them into these comparable groups, and then we just looked for the difference. Now, for the low-grade gliomas, as Marion explained, these are already tumors which are future glioblastomas, so low-grade gliomas, again, are grade 2 tumors, slowly growing, and they have this kind of inherent malignant transformation programmed. So they will turn into grade 4 tumors. So at the end, we could take the grade 4 evidence that I just showed you and extrapolate that on the grade 2 tumors and already say, okay, resection is good. Because this happens. This is a low-grade glioma, no contrast enhancement, and it turns into this kind of tumor, in this case already after 15 months.
So maybe in this patient it was already a more aggressive tumor than we saw on the MRI scan.
Yeah, this is an AV8 wild type. Yeah. Okay, so when you sit in front of a patient with a glioblastoma is this grade 4 tumor. You know that without treatment, the patient is dead within 3 or 4 months. That's such an aggressive tumor. So the question about surgery is quite simple. Or you have surgery and we do something, or you will be dead within 3 months. Now with the low-grade gliomas, this is much more complicated because it will be a glioblastoma eventually. But when we sit down with the patient at point 0, when we first see the patient, we don't know what the growth rate of this tumor is. It's not exponentially growing. It's slowly growing. And this will be glioblastoma, but we don't know if the patient has a growth curve like this or a steep growth curve like this. And the point is that when we do surgery for the patient at point 0 here, and the patient would have a very slow growing tumor, 1 millimeter per year, he would have also a very slow decline of his neurological functions. So this time here would be completely without any clinical deterioration. But if we would decide, because it's a future glioblastoma, to do the resection at this point and induce a deficit, then we would have taken away 4, 5, 6 good years of this patient. Unfortunately, low-grade glioma patients are very young. It's your age. So this is a huge responsibility, and therefore you have to think about brain tumor surgery in low-grade glioma patients at least twice. What we found, however, is that this is an old series. This is a traditional thing that we show, that there are better series now. But this is already showing the pivotal paper where we saw that if we do an aggressive resection early when the tumors are still very small, we have patients who survive without any tumor recurrence for 10 to 15 years. And when we take this data and look at what happened to the patients now, then we see that the patients are still alive without a tumor. So this is quite a definition of cure. And that is a game changer. When we do the right surgery at the right point, we can cure those patients. On the other hand, if we have a complication, the patient will have a neurological deficit, and that is language gone, motor gone, neuropsychological deficits, much too early. So you see that this is a very responsible decision-making process. And one thing that we will talk about, I think, on Tuesday, Wednesday, is that this long survival of those patients gives us also the huge responsibility to give them back with an intact neuropsychological situation. Talking and walking is not all. If a patient survives for 30 years or so and he is not socially intact, this is a big problem, not only for the patient but also for society. Okay, so what we can agree on after this data is that a gross total resection is the state of the art for the high-grade gliomas and for the low-grade gliomas. So we have a job. We definitely have a job. Now, when we look at the MRI scans, which we'll explain later on a little bit specifically, the criteria for complete resection, and this is not the biological complete resection, not be confused, that is not a cure, is that we have removed all contrast enhancement for the high-grade gliomas, and for the low-grade gliomas, we take a different endpoint. It's the residual flare or T2 imaging that we aim at. For those who are not familiar with that, in the MRI scan, we have different sequences. We have the contrast-enhanced sequence. We have T2, which is showing water. and the flare, which is the attenuated water registration. We show some examples later.
Can I ask a question? Wait, you wanted to ask a question. So my question is this. Look at the low-grade gliomas, and it creates a dilemma, which you put very clearly. The question is there any data, because the low-grade glioma can hit the patient at any location in the brain. So the projected functional deficit of a resection varies depending on the location of the tumor. Do you take this kind of thing? Is there any evidence that allows you to take the location of the tumor into account while thinking about whether you should or should not do a resection? And if so, how? How do you take this into consideration?
Absolutely, that's all what we're doing. We are looking at the location, we analyze the danger points, and we will do this in the course together, in several cases to train you. And then we decide, is it a resectable tumor? Of course it's a resectable tumor always. We just get in, get it out, and then the tumor is out and it's resected. But that is not what we want. We want to have the balance between functionality and the need for resection. So need for resection we have defined, and that is basically the pivotal question, or the central question of our lectures, how to prevent deficits and how to analyze the deficits. Yeah.
This is the point, how to analyze deficits. So you make the point in language, because we are operating in Broca's area and standing in front of the patient quite proud and say, okay, you don't have any language deficit, and then you are coming and say, well, testing language. So this is a very important question, but I have to go back to my question.
But my question was not intended to underscore this.
No.
Rather, it was intended to see if there's any evidence about taking the functional deficit into consideration in resecting low-grade gliomas. Is there any statistical evidence of any sort that will give you a clue
About the outcome?
about the relevance of the location, for instance, or something like this? Is there any breakdown of data from low-grade gliomas that looks at the specific function that's at issue as a measure of quality of life or something like that? So the dilemma is between resecting it or letting it grow slowly and let the patient have a high quality life. That's the dilemma.
That's the dilemma.
Yes.
When you're asking what is better for the functionality of the patient, or do the resection or to wait, then we have to answer that it's probably the resection. Better for the functionality, because the progression of the tumor destroys much more than the surgery.
Right.
As long as we know what we're doing. We have certain parameters where we would definitely stop surgery. For example, if we interfere with language and the patient is a university professor, then of course, if he tells us, I would rather die than not speak anymore, then we would stop there. Yeah? But that is what is difficult.
But my question was a little bit different. I mean, it's like it's touching exactly that topic. The question is there any data about different functions and how they get into your decision making?
I think we can't really answer your question, because their function we can quite easily detect and then monitor during surgery, or we can quite easily tell the patient after surgery there will be a paresis of your hand, your arm, your leg. That's quite easy. But there are also things like neurocognition. You can't really, it's difficult to test, and you can't really say what neurocognitive deficit the patient will have after surgery. Because you can operate on the same region and you can have 3 patients and they all come out differently, although it's the same region. And the difficulty of this question, the answer is that we all use our brains in a different way. And there are patients or people using more brain, say it like that, than other people. So it's, I think you can't really answer that question. That is why we're coming at the end. It's a very individual question, and you really have to talk to your patient. What is your risk for the operation, and what is the risk if you're not operate? And this is very individual.
will come back.
Definitely. More questions? Okay, so then we go to the basics of diagnostics. So how do we recognize these tumors, and how do we diagnose them? Well, the symptoms of a brain tumor are like that. They're very dependent on the location. Where is the tumor? And it's a huge sort of symptoms, from headaches, seizures, neurological deficits, and it's dependent not only on the tumor localization, but also is it slow-growing or rapid-growing tumor. For example, this slow-growing tumor, it's not unusual that we got a young patient with a huge tumor and officially nobody recognized anything. And then there's an epileptic seizure and you see this 5-6 centimeter big tumor and nothing else. In a rapid-growing, in a glioblastoma, we estimate that the neurological deficits will be recognized a bit earlier or easier. So they are coming with neurological deficits. And second problem, behavioral changes. The glioblastoma patient, the normal glioblastoma patient, is around 60. So if you get a bit dizzy, if you get old, and if you forget something, nobody really thinks of a brain tumor. It's just because, well, you're old. Of course, you can forget something. Of course, you can change words. Of course, you can do this. So it can be really difficult to diagnose it from the neurological symptoms. And another point is that there was a huge series for the low-grade gliomas, because these are patients in your age, young patients, completely in life, and nobody really recognized that there's a tumor inside the brains. But if you really neurocognitively examine them in a manner we don't usually do it, you will see the deficits. So the tumor is producing neurocognitive deficits. The question is how you recognize it. Do you use your brain in that way that you recognize it earlier than another one? And how do you test that?
Sorry, can you go back? This is I'm responsible for this slide, and I put it in because it is just textbook knowledge. There's one symptom which is completely irrelevant to brain tumors. What would you think? When I tell you that brain tumors are very rare, there's one symptom on it which is completely irrelevant. Headache, exactly. So what is the usual cause of a young student who has headaches? Did you say alcohol? Yeah. So headache is very unspecific. And as a brain tumor surgeon who does awake surgery, I can tell you that the brain does not really feel pain, obviously not. So headache is a very, very unspecific symptom, but usually it leads to the diagnosis of brain tumors, because if you're suffering, especially young people can have chronic headaches, and you go to a medical doctor in Germany, you get an MRI scan, nowadays quite easy. And then you get the diagnosis of a low-grade glioma. And then, of course, you're in a big problem, because you know that you will die of a glioblastoma, and you lose this time where you are asymptomatic, and we call this incidental findings. And this is a specific group of patients that we really have problems with, because they are completely healthy. They went to the doctor to get an MRI scan because they have headaches, and they come out with a malignant brain tumor. This is a very strange life situation, and we have to cope with this kind of patients. And I told you how dangerous it would be to remove that tumor. So headaches, forgot about that.
Also, I should note two things. One, with respect to headache, I'll tell them a secret about you, which is that one of his most favorite activities in life is to make whiskey.
No, Tim, not whiskey. Whiskey is very dangerous. No. You have to I'm just distilling. Not me, it's my medical students who do that. You have a competition of good. But what does gin have to do with headache?
So, I don't know.
You have just a drink on the rig.
I'm not such an expert as you are. But the thing is, one thing to remember with respect to incidental findings, and this should not dissuade you from being tested, but when you go to an fMRI you know, no, I'm serious. This
Yeah.
is something you should know. You're also, there are incidental findings in populations who go to fMRI studies. I don't know if any of who's doing the fMRI experiments. Anyone? Okay. I don't know if you've experienced having a subject with incidental findings, but one thing you should know is that, at least true of the past, of like 2 years ago, the head of the radiology department in Hadassah, who's in charge, the clinical director of our magnet, Professor Gomori, insists on looking at every single, or at least insisted on looking at every single MRI of every subject who went through the magnet here, just to detect such possible things. So these things do happen, you know, if you happen to pass through the magnet and have it, again, the likelihoods are extremely small, that's clear, but these incidental findings do occur on occasion.
And there's a quite interesting study from the French group, because there's a really famous neurosurgeon only resecting low-grade gliomas, and he's telling us that as early as possible, as aggressive as possible, he almost can cure these patients. So he went that next step and said, okay, so if I can cure the patient, it's very important to do MRI scans in the early way to look if you've got a low-grade glioma or not, because you don't recognize it. And then there's a problem of other diseases like aneurysms, other incidental stuff you can find in your brain. It's a really difficult calculation. Actually, you have a question.
Yeah, my question is all low-grade glioma will definitely go to high grade or part of it?
It's just a question of time.
Always.
All of them?
Always.
Okay, so then the decision for resection is that definite. You have to go, then you have to go for a resection. Not to wait and see or to I
think that's a big question. I mean, the timing is a question. So if you are just before you finish your PhD thesis, you have headaches, you go to the MRI scanner, and they tell you have a low-grade glioma, very near to your language area, or your your writing or reading area. It would be a very bad idea to do the surgery before you finish your PhD thesis. And it's very important to time the surgery. And we will just come up with an example of how you can identify activity in the low-grade glioma that can give the surgeon more clues to counsel you regarding that. But in the end, of course, you should have it removed, as long as the symptoms that you could have after the removal are compatible with your quality of life and with your individual definition of quality of life. That
it's sooner or later resection.
Let's put it here. It's easier. If your endpoint is overall survival time, then you must go for surgery.
Okay. Yeah, I'm asking because I'm working in images. Some colleagues, they send us some patients for follow-up. Is it grade, higher grade? Why they ask? Is it for timing or for something else?
The therapy is over the last years is getting more and more aggressive for low-grade gliomas as well because of that point. So now we are quite sure to say if we operate as early as possible, we can prolong survival. But the problem is that there are some tumors in some locations when we do the operation quite as aggressive as we want, the patient will have permanent deficits. So these are the patients we're doing different kind of images to get a hint. What kind of tumor is it? Is it a low-grade glioma? Is it still slow growing, or are there maybe part of this tumor cells already changing, getting more aggressive? So for this question, when is the best timing to do the operation and risk this permanent deficit.
Do they ask you to make a volume of the tumor to evaluate the progression?
No.
So you're working in diagnostic radiology, or
It's with feedback.
it's FET? Yeah, it's this we're coming up.
Yeah. So they asked us for the, and sometimes it's not available. We have TOPA. So we see the uptake and we give everything low grade.
Just stop here. We just come to this point
Okay.
in I think 4 slides.
Okay.
We got only one slide of it, but it's very important. Yes. So, coming now to imaging. So there are few experts of imaging. The most important is still MRI with or without contrast enhancement. And it's very important to get an actual MRI scan, so it shouldn't be older than 2 or 3 weeks, so I can really tell the patient what I see at the time. So some examples of expected low-grade glioma, PHO type 2, so a slow-growing glioma, I wouldn't expect any contrast enhancement. So if there's a lesion which I can maybe better see on T1, T2 imaging, where it's lighter than T2 imaging, T1. So this is a typical picture of a slow-growing tumor. If there's already some hint of contrast enhancement, I would guess, okay, there might be contrast enhancement. There might be already malignant transformation.
You have to tell ignorance like me what you mean by contrast enhancement.
Okay, so the contrast MRI pictures. So this is a T1 with contrast enhancement. As you can see, there are some light dots. Contrast enhancement is given via IV. So in vessels, there you're allowed to see the contrast enhancement because it's normal. It's running through the vessels. But it's not normal in the brain tissue because normally there's no vessels. The vessels are around the tissue, inside the tissue. So if you've got a tissue area which is not looking normal, and there you got a contrast enhancement, this contrast enhancement is running out of the vessels because of the disrupted blood-brain barrier into the tumor tissue. And this is the point where we think, okay, here the tumor is so aggressive that the blood-brain barrier is disrupted and this contrast enhancement can go through. And this is where we're thinking of malignant transformation. And this is a CAT scan, CT scan, so this is not very important. Sometimes when the patient is coming because of an epileptic seizure, if you're doing first a CT scan, but more important is the MRI scan.
But isn't it true that in this case, the reason you think that there's a problem with blood-brain barrier is because you see that it's close to the lateral ventricle, or it's like an independent issue?
So you see this white dot there with the yellow
Yes,
arrows.
so that I see, but the tumor itself is compressing the lateral ventricle.
Here you can see actually a typical picture of a starting slow-growing tumor, because it's quite a mass. If you would have this mass from one day to another, you would be dead or in the emergency room right away. This patient is coming most because of an epileptic seizure. And the ventricles, you can see the ventricles is pushed aside. So the tumor volume is already pushing the normal brain tissue aside. And it's not in the ventricle, it's just in the tissue, this contrast enhancement. Yeah.
What is the contrast enhancement attached to? Like what part of the cell, or it moves through the blood and then goes
Out of the blood.
out of the blood-brain barrier?
Yeah.
Does it attack something specific, or does it just stay there until it's
Stays
released?
there. This is
Well,
Specific to one like kill molecule or something like that?
so it's the idea, what our perception of the contrast enhancement is that it is a leak, that it's leaking through the not perfect blood-brain barrier, and it's leaking out into the glia cells, and it stays there for a certain time, and then it's washed out. Yeah, through the ALF.
But doesn't it attach to something? Or what is it color?
it's not attached to anything.
Well, as far as I know, to be honest, I just it's leakage, but it's not attaching to anything. And this is one or the classic picture of an WHO grade 4 glioma, so a rapid growing glioma. This is again T1 because fluid is dark with contrast enhancement, and you can see all these light spots in the ventricle. These are vessels. They are allowed. They are allowed to where you can see the contrast enhancement. But the tumor tissue and the surrounding, it's not supposed to be contrast or positive. So there's a leakage, and in the middle, you can see this dark spot, and there is this necrotic tissue area. So the tumor is so rapid growing that you got in the middle a necrotic tissue area. So Yusuf told us we should be as practical as possible. So here's a little case of a young patient, 32 years, and he got a focal seizure, and he's a piano player. Then after the seizure with no further deficit. And he got a CT scan, and this is quite an old case. That's why we will lateralize, so this is the left region, this is the right region. Nowadays, now it's changing again, but when I started medicine, it was very difficult for me because the MRI scans were the wrong way because you look from down and the CAT scan was from up, so it was left, right. So this is the left region, and we will talk about anatomy a little, or what, are you familiar with the brain anatomy? Can you say the, okay, perfect. So what do you think? Oh, that's great. So what do you think? Where's the tumor located? Also say it's
looking like it's a frontal, like it's hard for me to say, but I would guess like the areas around the frontal temporal, maybe not so temporal, but frontal.
It's a frontal lesion. If you're looking on that side, do you have a guess what this might be? So if you're looking at the anatomy, it's almost easier to look on the other side because the tumor did not affect the anatomy, so it's easier to see. So as you say, it's left frontal, and here there might be the hand notch of the motor area. So it's a precentral tumor, explaining why he got a seizure and why he couldn't play the piano during the seizure. On the left side, he's got also speech harassment during a seizure. This is an old MRI scan. This is without contrast enhancement, and this is with contrast enhancement, and there you can see just a slight spot. So what do you think now about the location of the tumor? Is it just easy going, or will it be difficult, or is it what we then call them eloquent located? Are there important networks, tissues around the tumors?
So at this point of the diagnosis and the decision, how important for you it is to know anything about the functional deficit that the patient has? Because in a sense, your decisions so far are not guided by the functional deficit. They're guided by the clinical, by the lab findings, but not so much by the clinical, like patient science, the clinical science, like, you know, he has a problem playing the piano.
Well, we will talk on that on day 4 or 5. This is a very important neuro-oncology because now we're talking about a case. There's something in the brain in somebody. If we're talking about the patient, in this patient, particular patient, it's a piano player, and now we have to decide: should we go on for surgery should we just took a biopsy to get the diagnosis, or should we go for an aggressive resection? And then it's get important, where is the tumor located, what do we think what it is, what we suspect, what kind of tumor, and what kind of deficit do we have to calculate. And of course, if it's a piano player living from music, and it's a central lesion where we can affect his piano, his motor deficits, it's very important for the patient. So maybe in this patient, it might be better just to take off a biopsy to not risk any permanent deficit at that time.
I mean, this is a case. This is just about diagnostics. It's not about surgery at the moment. But you see that the point here is that the patient now is perfect. He has nothing. He has no deficit. But he had this focal seizure, inducing a speech arrest and a problem with right hand. So it was happening just the day before he did the concert at the Tonhalle, and he couldn't do this. And now we need to make a decision, and the decision is a little at the moment depending on the imaging that we have. And now we see that there is in this huge low intensity part of the tumor an enhancement, and we just learned that enhancement is not good because it shows that the blood-brain barrier is disrupted, and it's a sign of high-grade glioma. Now, on the one hand, we have the high-grade glioma here, at least a suspicion of that, and on the other hand, we have a highly eloquent lesion in a patient who cannot afford not to have a deficit, cannot afford to have a deficit in his right hand, and he's also a singer, so he must have an intact voice. So Maya was just asking the question: what is the problem if you see this white dot in terms of functional anatomy? Sorry?
It's in the central zone.
It's exactly what Marion told you to look at the healthy side. You see this is the cortical spinal tract going down because it's entering into the brainstem. And here you see the precentral sulcus. We saw it even better in the CT scan. So that's what Marion pointed out. Here's the lesion, and here you see this omega sign. So it's very near to the motor areas. And the point that we wanted to make with this case is that we now see this white dot. And we just see a white dot, which is potentially malignant. And we need more information about this white dot, because if it's not a sign of malignancy, then we could say, okay, so you have a series of concerns. And you're okay now, we give you some anti-epileptic drugs, and you won't have a seizure with a likeliness of 95%. Go on with your life, and we observe the tumor, because the resection there seems to be very difficult. But if we have a proof of malignancy, then this is a game changer because it's exponential growth. And therefore, we decided to go for FET PET. Right? And the FET PET, would you like to explain it?
Actually, it would be nice if you go there so we can hear it.
Oh, I can give you the microphone.
Come here.
No, because we know it's not going to get recorded. So, why don't you go?
First of all, are you aware of the nuclear medicine procedures? So, in nuclear medicine, we inject.
Speak louder.
Yeah. So this is a PET-CT with FET. PET-CT is a nuclear medicine procedure. We inject radioactive material which go in the brain. MRI, it's a structural image, and this is a functional image. In functional image, we know how the cells are functioning. So we know the behavior. So in MRI, we have how it looks like, and in PET, we see how's the metabolic activity. So the most famous PET image is FDG. It will show us glucose, the sugar metabolic activity of any required tissue. In this peptide, we are concerned about amino acid metabolic activity in any tissue. We have learned that more aggressive the tumor, it will show more uptake of the amino acid, and it will show a specific way of care of uptake and washout. So with more uptake, we are more concerned that it's more aggressive, and it will show also, we do a dynamic images which show a specific phase of uptake and washout, and through the uptake and washout, you know how these cells are functioning. So here we see the image, and it's with more radioactive material uptake. So here we say it's a tumor with higher grade. It's with high grade. Of course, there is differential diagnosis we have to keep in mind, but in such a case, and also we have to see the dynamic, but with such uptake, we are concerned about high grade tumor. Of course, we have quantitative measurement, because as we can see also the normal tissue, it's also taking the radioactive material. So we see how much the concerned lesion take activity, and we compare it with the abnormal reference area in the brain, and through a threshold or a cutoff point, we can say, yeah, this is a higher grade, this is a lower grade.
Thank you.
Thank you very much. So I try to explain to our patient that the MRI scan is more a passive image. So you get this contrast enhancement into your veins, and maybe it gets out because of the disrupted blood-brain barrier or not. This is an active image where the whole brain cells are consuming the contrast enhancement. So I can differentiate, is there an active part of the tumor, more active, and that's what you already said, there was supposed to be the more aggressive part of the tumor or not. So actually, these are the most true important images we're working with in Düsseldorf. And this, we're using PET imaging. In this case, it's not that important. It's more important in tumors that have no contrast enhancement. So even if I can't see any contrast enhancement in MRI, there might be a hot spot in PET. So there might be a more aggressive part already in the tumor, and even it's getting more important after therapy. So after surgery, after radiotherapy, after chemotherapy, after immunotherapy, we see more and more changes. Of course, the brain tissue, we change the brain tumor tissue. But because of the changes, it's getting more and more difficult to differentiate, what do I see? Do I see now scar tissue? Do I see reaction after radiotherapy, or do I see a progressive tumor? So this is a very important imaging for us to differentiate between active tumor tissue or not. Of course, there are a lot more, and I think maybe I should go quite quick because we need a break and we need to prepare the brains, right?
We just talked, we can make another session, and after that we would suggest that you have a break, provided that you come back.
Okay, so just quickly, I mean, we got already the specialist. What about more advanced additional imaging about eloquent areas? How can I identify? We already heard that cortical lesions, cortical eloquent structures can be identified by functional MRI, where the patient has to do, during MRI, has to do some working, and we can see where's language, where's motor area. Like in this example, we can do the same with transcranial magnetic stimulation, so where the brain is stimulated and the patient has also to do some work, and we can see where's the language or where are the motor areas, and we can put these image into neural navigation. So we got a slide or good overview about the eloquent cortical regions. And of course we can identify subcortical tissue by diffusion tensor imaging, so DTI, so where the fiber tract's going. For example, in this central located tumor, I don't think you can see it good, but so these are the MRI scans, and you can see this left tumor tissue, and we're thinking now, okay, where's the language, where's the motor area, so how can I go, from which direction is the best direction to go into the tumor? So we can use DTI to think about the way, so where are the fibers moved by the tumor? The tumor tissue is changing our eloquent areas, and it's moving the motor area, for example, in other directions. So the DTI can help us identifying a good way into the tumor, so we can plan our surgery. But this advanced imaging is very dependent on where you're working, what are you familiar with, and depending on local philosophy. And that I think we will explain in the next sessions. And right now there would be a good point for a break. Okay?
Is that okay? So we during the break, we will prepare the brains for this practical session that we'll have at the end. And we should have a break of 3 minutes.
Let's make it 20. How about 20?
Okay. See you in 20 minutes. We see you in 20 minutes. 5 past.
Anyone of the students who are registered for the class who hasn't put down his or her name, please do. I don't have a pen. I actually have two.
So when you show the black and red lines, it's the relation between the low grade and a lot of increase amount of people staying alive for months. So
Okay, shall I go bring the brains?
Should I come with you?
Sure.
even though like recognize the words and individuals,
understand why this is really hard.
Follow the IDH from 2021, I guess.
Yeah, because I can't understand why people told me that 10 years ago. Now I have
complement the MRI ones. And the example you gave, they make the same picture. So I wonder about cases where you see this impaired, like this kind of region that is focused and you don't see it in MRI. What does it tell you? Like the mismatch kind of.
We wanted to make it more complicated.
Yeah.
That is more interesting after surgery. We have scar tissue. Scar tissue is contrast. So I've got the scar tissue contrast. Then the radiologist can decide if you can see scar tissue contrast.
So you have
So it's also the problem in PET, right? Or with just
But if you've got contrast enhancement then the radiologist would say, okay, you can look at those pictures, and this can be tumor or it can be related to radiotherapy. And then we will if there's no hotspot, not active, then we say,
Does anybody of you have a pocket knife? Large knife.
differentiate between tumor or radiotherapy changes, contrast enhancement tumor or active tumor.
so in the back you wouldn't see anymore like this kind of.
Yes.
Thank you very much.
usually happens when we do this as a residence. The guys who clean up, just throw the brains in the trash can. The trash can is eventually cleaned after 3 or 4 days. It's like smelling like water.
Almost the reason why you got quiet.
raise that. Anybody interested? Right? No? Circulate that maybe in two parts.
I have a naive question. Why do you use the MRI for the metabolism? Why use PET and not fMRI? Something like fMRI. I mean, fMRI also measures the level of metabolism.
People, if you just discuss the right to MRI for detection of you could probably do that. The best data that we have really agrees with invasive. And it's also practical.
Just a curiosity, is it a contrast between without the contrasting? What do you contrast it with? When you pick up the signal, it's the signal between what and what. The brain is noisy.
Yeah.
So it's between without the contrasting material.
Okay, yeah. First, we see the structure of the test.
This is without it before you inject it.
No, it's a different thing. The colleagues in radiology, they will do MRI. And they will describe it.
Okay.
And colleagues, they will ask us a specific question.
Okay.
Yeah, because we can't, it's a function. You don't see the structure. So they will say, for us, for example, we have a lesion, and this lesion, please either say, is it a high grade or so we can characterize.
Yes, but what is the basic contrast that helps you get your indications? You know, you get a signal.
Okay.
And the signal is some kind of a contrast now. What is contrasted?
Yeah, we take a reference point.
Yes.
We take a healthy part of the brain.
I see. Okay. So
Yeah.
All right.
If it's structural
I got
patients,
you.
we say,
Okay.
yeah, this is a healthy brain, and we take it as a reference point.
I see.
And
So
we
you-
do, yeah, exactly, and we do a cutoff points. And so we say, for this region, above this border, now we have higher signal.
I see. So your reference is signal intensity within the same brain.
Yeah, exactly.
Between the suspected,
Yeah.
the
Because,
suspected tumor
yeah.
and some area that you
No.
don't see anything.
Yeah, exactly. So
Okay.
sometimes it's very clear.
But this is after the contrasting agent injected. Thanks for the presentation. All right. I'm going to move away from here.
You stay here and you tell us when it's time to start. Just a second.
No. Oh, just by smelling. Thank you, sir.
Can we shut off the light a little bit?
You don't, right. By now you don't need the screen. Oh, you do need the screen.
Yeah.
I see.
This is the end. Okay. So you see what we see here, and here is very small amounts MRI. Especially here, we take the data of the MRI into a new navigational machine, and we have, if we observe it, we have a tip, an instrument available, and see where the tip is located on the brain, and this is the new navigation. You see that this is quite technical. What is, I think one of the things that is also important about neurosurgery is that you can do it very technically, very technically, depending on the technology, or you can make it on a more basic level, which is just taking advantage of very simple landmarks. And I just want to show you that because it is very interesting that if you learn anatomy of the skull and of the brain, you can always apply it to the localization on the patient. And we'll make some simple examples. So the first thing is, if you look at the skull, you see some marks on the skull, some landmarks on the skull. First thing is that you see the sutures, the fusion of the frontal lobe with the parietal lobe, of the temporal bone with the frontal and parietal bone. So these sutures are visible as soon as you make a skin excision expose the skull. And as you can see here, we have the coronal suture, which can be found on the skull at the mid of the connection line between lateral orbital, this thing that you can touch here, and tip of the so-called tragus here. So just in the midline between that, going up, you have the coronal suture. And if you have the coronal suture, you see that you have also the anatomy of the brain. It's circulated, just circulated in motion. Also have it, look at it. You have correlation between the coronal suture and the brain. You see that one lobe gets going from here to posterior, and then you have the cross-section here. And the other lobe is basically going perpendicular to the in front of the back. And then you have this other lobe going down to the torso and down. And this is the motor side. The left side, looking at the you can see that the motor functions are about 2 centimeters behind the brain. And that is the case that we will discuss Thursday. So we have done this on the MRI scan and estimated that the tumor that we wanted to operate on is very near to the central sulcus, which is dividing the frontal lobe, precentral sulcus, which is dividing the frontal lobe from the motor cortex.
Can you speak a little more? It's difficult. Or should I give you
Okay, if you catch me so far, or shall I repeat it? The important thing is that when we look at the skull, we have the landmark, the coronal suture, and from the coronal suture we will find a very important motor function. So this is also true for a different landmark. If you want to find this tumor in the patient, I can show you exactly on my skull where this tumor is located. Why? Because we have landmarks here. So this lesion is on the left side of the brain. It is in the frontal lobe You see here, there's a division between frontal lobe, temporal lobe, parietal lobe, which is called Sylvian fissure, or it's also called sulcus lateralis, lateral sulcus. It's very important because first it's very good landmark because it divides frontal from temporal, and because the most important brain vessels runs through the sulcus. The middle cerebral artery. You see it here. Here's the artery running through the sulcus. So the tumor is located partly frontal, above the temporal, above the vessels, and that is exactly the localization where a bone spur, the so-called clinoid process, is dividing the frontal lobe from the temporal. So as soon as we know where this bone attaches to the skull, we know the division between frontal and temporal. And that is the so-called pterion. Pterion, the lateral clinoid process attached to the skull. And therefore, we have here the division between frontal and temporal. Very, very simple. And the interesting thing is as soon as you expose the skull, you can touch it because it's a little groove. So, high-tech technology, high-tech imaging, new navigation, integration of thousands of meters comes down by just touching the skull. Okay. So, again, we project the pterion to
let me ask you a question. So we all know that there's tons of studies about anatomical variation at every level. Do you know of studies of anatomical variation of the position of these sutures, on the skull? Like variations in skull structure with respect to these landmarks?
There will be, because in medicine everything is possible. But for practical purposes, this is just when we don't know it, it must be less than 1%, 4.5%. So it's not had no practical implications. Yeah, there will be some variations of the features.
No practical implications with respect to it being a good predictor of gyral. I see. So
very rare. There's children born with deformed sutures. This is deformed skulls. They don't have that. But they are recognized, and we know that, and they would, of course, if you would look for a suture, not get that approach.
But my question is quite specific, and it goes like this. We know there's a lot of variation, even in brain size. What you're telling me now is that most of the relevant variation in terms of the topography of the brain, it co-varies with skull landmarks. So brains vary in size and shape and so on and so forth, and it makes perfect sense to think that they somehow co-vary with skull structure. So if your brain is flatter, maybe there's something about your skull because that determines it. So they go to, what you're telling me is that they're a good predictor. So they go together. The variability in skull structure, in the sense of those sutures,
they are correlated.
Is correlated with.
We will still, even if you have a deformed skull, we will always have this clinoid process. We will always have the frontal temporal lobe, and that will always be the division.
I wonder if there are any studies of this. I'm sure there's some.
This is working with academics. You're really in ivory tower because this is not relevant.
Hey, come on! I want to know if you're.
The only thing that I can tell you is relevant in terms of skull structure is this area here, because if you have an approach to the cerebellum, you have to put the patient in a peculiar position, and the exposure of the cerebellum is highly dependent on the angle this bone makes. It can be very flat, and it can be very steep. Steep is good. Flat is making certain.
So it doesn't correlate with cerebellar
Sometimes it does not really correlate, or the cerebellum will be here, but the approach will be very difficult because we have to have a very exceptional positioning of the patient.
Yeah.
Right? So the point that we want to make here is that you can break down neuronavigation or localization of the brain to very simple points. And this is a Sylvian tissue. You can find it very easily by just touching this point here, finding the groove, and then draw a line here. And then you already have the division between frontal and temporal lobe. At a certain point on the Sylvian fissure, above the ear, that's all you need to know, going up, you have the central sulcus, and then you have here the motor cortex, and here the somatosensory cortex. Extremely simple and very reliable, apart from your exceptions.
And sorry, it's also very important to know that, because when I started my residency, we didn't have this neuronavigation and all that fancy stuff. So we went there with a centimeter mask and look at the MRI scans and said, okay, from here to here it's okay, so the tumor must be around here. And because of the anatomical and the MRI scans, we got a picture of where should the tumor be. Now, the resident on your side is and you get this 3D plan of your head, and you're taking a point, and you just point to the head, to the fixated head, and the neuronavigation tells you where the tumor is. But of course, it's just a machine, and of course, it's not 100%, and of course, there are mistakes, and maybe it's just a slight change that it's not exactly in that position, but 2 centimeters away or 0.5 centimeters. And if you've got no clue about the anatomy, you just go for the neuronavigation and you're completely lost. So you really have to know the anatomy as well.
So let me bug you with another question of the same kind. Because I have seen you, this is my job here. I have seen you making these decisions in the OR, and they will probably see them. And sometimes the hole that you make, I mean, the piece of the skull that you remove is big, and sometimes it's small. Do you know of any study, I'm being very academic, okay, that indicates that since the introduction of those navigational devices, the size of the hole in the skull that you make is smaller?
This can help you, yes. It has been shown that it's more precise, and the craniotomy, that's how it's called, shrinked in size, and it became much more precise. But at a certain point, especially due to us and our friends who do this brain tumor surgery, we reinvented the large craniotomy for reasons that we are going to demonstrate tomorrow, because we want to expose the motor cortex, because we take it as a reference point for the thresholds of electricity that we take for it.
But that's an independent question.
Yeah, that's okay. Another thing that you could ask now is, did neuronavigation make resections better?
That's the whoa.
And it doesn't. It doesn't, because we have the problem with the brain shift. And if you rely on the neuronavigation showing you the limits of the tumor, you're lost. It's even somehow contraindicated to do that, at least in our hands, in our experience. Because as Marian said, you have a brain shift, and the imaging that we do with the neuronavigations have been done with the patient prone in the MRI scanner a couple of days before surgery. And during surgery, he's probably lying like this. We have already removed part of the tissue, and the brain is falling down, and it is not at the point where the neuronavigation tells us it's supposed to be. Okay? So, coming back to these very simple observations on the skull, and the reflection where the tumor is, we take the Sylvian fissure, and skull, Sylvian fissure, pterium, and you see that this is where the clinoid process is not. The clinoid process is showing how it divides the frontal lobe and the temporal lobe, and here's the Sylvian fissure. Okay, now applying this to the case that I just demonstrated. Okay, you have to explain. That's too tough.
Okay, now a little fun fact is coming. So we got now all the anatomy, but of course we can think about the possible tumor localization. Sorry, excuse me. So we can think about the tumor localization by neurological deficits. For example, speech arrest or paresis of the hand. And this is now an example of a young male.
Of course, male.
Of course, male. So after tumor surgery, he was released, and this is a postcard. He sent it to the nurses of our ward. And he said, okay, thank you to all the nurses, best wishes, and I promise that I will send you a picture of my holidays, of my summer holidays, and maybe you will be happy to see this picture.
So where's the lesion?
So I don't know about Israel, but in Germany this is not appropriate. So you wouldn't do this.
So the next picture will be to Germany.
So what do you think? Where might be the lesion? Do you have a guess? Oh, sorry. You. So it's a frontal lesion. So yes, this is a fun fact, but it also demonstrates a very serious side effect of surgery. So we're not only talking about paresis and speech arrest, we're also talking about, and this is way more important for the patient, for most of the patients, neurocognitive deficit and changes of psychology. So just beside.
That is one of the points where we're still quite bad at testing. And all of you studying new psychology, looking at this, you will be very helpful for preventing something like that. Just for one. So, let's do a little anatomical training.
Was?
Where's the lesion? So what you would like you to show it.
Wait. Can I bug you about this patient? Because you see
the naked one.
The naked one.
Yeah, I thought that would be interesting.
but not about the nakedness. You see, I have to tell you, there's something that I don't like about stories, clinical stories like this. The message always is, with the brain, anything is possible. And I personally, I have an aversion to this. In fact, couple of the students here know that you probably know this book, The Man Who Mistook His Wife for a Hat. Okay, so once, when it came out in Hebrew, I wrote a review of it, which was quite scathing, because I think it's like total nonsense, this book. And the reason I bothered to do this is because I don't think there's something like anything is possible when it comes to the brain. If anything is possible, we should close this building and maybe turn it into a concert hall or something like this. The point is that there's something systematic and structural about it. And all of a sudden you come up with an anecdote. So let's stop with this anecdote and think what could have been done had you had access to the patient. It's not just a postcard. The question is, now the patient is coming back to you and he happens to have his pants on this particular day, and he said, look, I was arrested twice, in the past 3 months, please help me. And the question is, do you have a means to at least detect the location of the deficit?
That's a very, very important question. And we will exactly confront this problem, I think, tomorrow or the day after tomorrow. Because it is very, very easy, as you will see, to work in the motor region, to work with language the way we work with language. Not like Joseph wants us to work with language. But it's extremely difficult to estimate the new psychological deficit that we can induce into the patient. And that patient who didn't have a new psychological evaluation before surgery, because it was not the surgery who did this, he already had this disturbances before. He exaggerated. Exacerbated. Good to have a linguist. Accelerated this lesion, this deficit, and we did not recognize this because we did not do systematic psychological tests. We now starting with this, and that is, I think, the future of neuro-oncology to also take care of that. Very good. So, again, where's the lesion? Now, this is the anatomy, and I want you to put your finger on the lesion on your head. It's on the right side. Okay, sorry. Where is it? See? Here.
Anterior cingulate?
Sorry?
Anterior cingulate cortex?
show me your head and point your finger on the eye. Yeah, you're not, yeah, that's right. Exactly that position. Yes. You all agree?
It's rather deep.
Yes,
Because
deep.
the slice that you have is almost right down the middle.
Yeah, but okay.
So, yeah.
So what you see is the frontal lobe. You see the temporal lobe. Then you see that this is the ear, and this is the central region. The tumor must be in the region of the coronal suture, which is here. You agree? You can go back. Come spare the But you don't draw on my head.
No.
No, this is
Sorry, you usually immer raus
You don't go back again. It's okay.
So, sorry. You've got the ear, the eye, and right here must be the certain fissure, so you know it's above and behind the eye, so it's here located.
But from this slice, you don't know that it goes this much laterally. From this slice, just because it's a slice, it's a sagittal slice.
You don't say that it bridges the surface. You just say from this direction you will enter
Right.
the tumor.
You eventually
But
get.
you make a very good point. You have always to look at the location from two dimensions, anterior and posterior. Okay, so that is the localization of the lesion. Let's make the approach. How do you approach that? What would you recommend? You need to make a skin incision, and below the skin you will expose the temporal muscle. You can, if you touch both sides of your head and you bite, that's the temporal muscle. You can see the extension of the temporal muscle. Biting again, and then you're willing to stop here. That's hopefully something. That's the temporal line. This is the temporal line. So we make the skin incision. We expose the temporal muscle. Now we remove the temporal muscle, we flatten, make it flat. And then we have exposed the bone, temporal line, and here is the pterygium. So here is the attachment of the clinoid process, and this is a division of frontal to temporal. And we have decided that the tumor is located where? Here. Yeah, exactly. Yes, perfectly right. So we do craniotomy. It's breather stenotomy. Oops.
I just want to point out the brains of working out.
Smell test, short smell test.
Okay. So this is the cervical fissure, temporal lobe, and the tumor is located here. So now we go to surgery. You might speed up things.
Yeah.
So this testing for language, if you see the localization and the orientation is exactly the same. We are standing behind the patient. This is frontal. This is temporal. This is the cervical fissure.
Soll ich mal abmachen?
Hello?
Ja.
And get speed through it. This is a testing that we explain the day of tomorrow. Now we enter the cervical fissure. We just want to show that the tumor is located there. You can speed up. Split it, we test, and then we eventually remove. Again, the patient's awake at the time. We test and test. She has no language deficit. We would agree that it's very new to proper. That's okay.
How do you cut it, the tumor?
We have small portions. We have bipolar combination.
No, we asked about cutting. You don't cut it. It's something.
So what we we have mild maps as well, but usually you do the circumferential preparation of the tumor, and what you saw with an ultrasound aspirator,
which you can see here.
You can see that. It's like a dental suction.
So this was a metastasis, right? This tumor had some more defined border than the patient that we showed later. See that the tumor is already removed, and that removes the surrounding tissue to get the last bit of the tumor. And that is only possible because I tested it with a bipolar stimulation and I'm sure that there's no neurostructure. But that is not really the point that we want to make here. I just wanted to show you that we did this without any neuronavigation. We found this tumor because we just touched this one. So let's go back.
I think the missing thing here is that most of the tissue in this kind of tumor is already necrotic, anemic. And because of that, it's just some kind of, I don't know how you would describe it.
Yes, it's liquid or it's not functional. So
but it's not a tissue even.
Okay, that's the point we want to make. It's or it's liquid or it's very hard. It's like scar tissue. It's cartilage. Sometimes it's cartilage. Maybe we can make the point with the model that we have here, because the tumor is a little harder. But in the end, this is metastasis. This is exceptionally hard, and hard to distinguish. But normally, how do you describe it? If you work in the brain with a brain tumor, it's like working in a pudding, which is the brain. If you remove something which is a little like
hummus?
Hummus.
Yeah.
Hummus and pudding.
Hummus or tahini? You have to decide.
Okay, that's another case. And again, you decide what the localization is, very similar. But now, again, just for repetition, where is the tumor? Just point from your head. Where is it? Here. It's not behind your ear, it's before your ear. It's behind your eye. It's above the Sylvian fissure again. You see the Sylvian fissure here. So it must be, if you touch it, the fissure. Okay? So all of you won't need brain navigation if you apply for brain navigation. You don't need it. Okay, let's see. I think
So we're just thinking about now when we're planning the surgery, we think about where the eloquent structures are located. So with eloquent structures, speech, in this case, motor area. So again, detected on the healthy side.
So it's very easy to detect the cortical spinal tract if you have a coronal and eye. You see this is the brainstem, and the tissue, the fibers that enter the brainstem are the cortical spinal tract. We always start with the healthy side because the anatomy is not distorted. You see that the lesion here, this is the edema, is not at all correlated with motor function. So one danger point eliminated. But the problem that we have is, it is somewhat attached to the vessel seal. You can see this. You can see it here. And this is a medial cerebral artery branches, which are very important because they supply the blood supply for the hemisphere here. So they must not be injured. So analysis, structural concerns as far as the motor cortex and the subcortical structures of the motor functions not. But just as an example for function, the unit of intelligence, but vascular could be involved. Okay. So this is the patient, and we have exactly done what you did with your finger. We located the material, and we projected the tumor, this here, and then we defined the extent of the craniotomy. So it's a video.
Yeah.
Why do you take his eyes?
Excuse me?
Why do you take his eyes? Why always shut like that?
Because
Because if they open during surgery, and the surgery might take 2 hours or something like that, they will dry out. This is not the patient on the wall. This is the patient in surgery. He's intubated, ventilated already. He's ready for surgery. And this is a skin incision to be planned. this is a topic. Just go ahead again.
Ja, ist schon, jetzt geht's weiter. Okay, so before you see the next surgery video, how do we perform brain tumor surgery, we would like to explain some more basics. So we talk now a lot about preoperative imaging, like MRI scan, PET-PEN, function MRI. We talked a lot about anatomical structures, but now what's coming is how can I see the tumor intraoperatively? We already said the tumor tissue is different, and a normal brain tumor, it's like vanilla pudding or vanilla Grütze. What's Grütze in English? It's vanilla pudding. Let's stick to that. More scar tissue, or different from flavor, I would like to say, from the not tissue. And thank God surgery is very important to visualize fast-growing tumors. For example, this is an interesting picture where you can see the normal brain tissue, so this is put in the middle. Here it's getting a bit different. We've got a necrotic area, and here you can see it under the microscope, but it's getting difficult, more and more difficult, so more and more you go into the normal tissue. And therefore we start to fluorescence guided surgery. So this 5-aminolevolic acid, it's incorporated into the fast-growing tumor tissue, not slow-growing, but the fast-growing tumor tissue, and it's helping us to visualize the tumor tissue. So from this picture, we can take blue light, and then the fast-growing tumor tissue will appear pink. And not only pink, so this is a video as well. Oh, sorry.
This is not a good sign. So the important thing in this video, if we can show it, is that we did a study that was a study by tumor, which compared white light resection with microscope. In this case, I was finished with the surgery and said this was a complete resection because I don't have the feeling that there's any more tumor. And then I switched to blue light, and you see that there was still a substantial part of the tumor image. So that means already finishing the hemostasis.
Here you can see the bone, and here you can see everything looks quite normal, and then you push into the blue light and you can see, no, there's residual tumor. So it's helping us to visualize, and even in cortical areas where we couldn't really see the tumor, it will light up. And we already showed you that diagram, and it was made by this study. So all of these patients were selected by the surgeon when the surgeon said, yes, I can remove the tumor tissue as aggressive as possible. And then every patient got an MRI scan after surgery, at least 3 days after surgery. And then was checked, is there residual contrast enhancement, yes or no? And this study also showed that with this visualization of this pink, it's easier for the surgeon, and the surgeon can resect the tumor more aggressive and can get people more into this grayish line. So resection is more aggressive, more complete regarding the postoperative MRI scan, regarding less contrast enhancement on MRI scan. So here again the example of this classical glioblastoma on MRI with contrast enhancement, and we got the internal necrotic tissue, And then this fast-growing tumor tissue going up into this infiltrating zone. And here you can see the necrosis is grayish as well, but we can see the necrosis quite well under the microscope. And the infiltrating tumor, where it's going into this functional brain tissue, there we need this blue light again.
So how do you know that the area that you mark is non-functional?
We know it by mapping and monitoring. We don't know it just by the picture. We need to test this area to decide if it's functional or not, at least.
You have this very bright red stuff, which is what we see here in this brain. So this cannot be functional because it's the exponential growing. But ADS gives you also some kind of estimation about functionality.
Ich glaube jetzt. Sorry for that, but I think I got some problems with the.
I'm just worried about the brains warming up.
Zeigst du das dein Video, der ist wieder abgeschlossen? Sorry, it's not working. So this 5-ALA technique is very important for us, and it's very specific for the new diagnosed glioblastoma.
Hättest du kein HomeKit Zubehör installiert?
Lautzeiten, keine Ahnung. What is wrong with your computer?
I don't know what's wrong now. It's Apple. If you're doing a second surgery, it's more difficult to distinguish because it's also positive in glial tissue.
Turn down the volume.
So it's very difficult to see.
Yeah, but that was not inherent in the video.
Tumor
Yeah, whatever,
or not
just in case.
But for the first diagnosis, it's quite useful. And again, for the rapid growing tumors, not for the slow growing, but the rapid growing tumor in the infiltration zone. Okay, and now we will das Video runtersetzen.
Du willst erst noch das erzählen.
Aber das ist jetzt nicht gerade. So you can see it's a wake surgery, and we were testing the area, looking for eloquent structures. So can we resect it, yes or no? She's recognizing pictures and saying this is a lion, this is a horse. And the goal of the surgery is minimum resect the ALA positive tumor tissue, because this is the area, the tumor tissue, where we expect the more aggressive tumor cells. So this is helping us being more aggressive.
Should I turn on the light?
No?
No. I would like to show you another video of a young resident learning how to resect brain tumors.
So this is a case with a right frontal lobe tumor, which you have already seen in the MRI scan. So it starts with the positioning. Put the patients in the so-called Mayfield clamp to immobilize this patient. Also in the wake surgery we do this. And this is a very important, just to show you how dependent we are on technical details. There's a point where the headrest where the patient is lying in is removed, and the Mayfield clamp is attached to the table. If you don't have very precise communication and just chatting away, saying, "Oh, my weekend was very nice with you," and then you don't realize that the guy who's helping you is taking away the headrest, the head will drop, and as the patient is relaxed, he has no tension in the muscles, he will have immediately broken neck. This is shown here that we very slowly and with communication take away the headrest. So with this surgery, with this video, we want to just show you a basic, simple, very simple brain tumor surgery to make you familiar with this. And we do the brain scans, and we do the navigation setup. Now we have the navigation ready. And then again, we do the thing that we did with you. We ask the resident where is the tumor located. And she has the same information about this as you have, so she is showing us. And she's doing the same thing as you did. Thinking about, is it really right? Okay, and she's simulating. This is interesting. That's what we're doing all the time. That we simulate the surgery, and she's simulating the incisions she's about to make. Now you see that we have the navigation available. We move the head accordingly so we have the right position. And then she shows me again where the tumor is located, and she's wrong, so I correct her. So this is Sylvian Fisher. We know where the localization of the tumor is. We check that with the navigation just to convince her that I'm right. See? So this is teaching. You have her showing where the tumor is, and we give her the confirmation, and then she is confident that the localization of the tumor is really there because the machine is showing it. And that's always a very difficult thing, I think, in our technology, that we believe the machine and not our common sense. Okay, we go on. That is a skin incision that we need to expose the craniotomy. That's the preterion, a very important structure, and that's the bone flap that we're planning. Very simple. Sorry, I have to show you here. And that's what you see in your mind. That behind. So it's draping. This is real time. I'm very fast. That's one of my favorite things. Now, this is interesting, psychological wise. She was prepared for the surgery, and she was asked to do her first brain tumor surgery. What's happening here is that the old white guy in the OR gets a knife, but it was supposed to get to her to get the knife. So I give her the knife, and she's standing like this, and she doesn't want to do surgery. Eventually,
let me stop here for a second. I just want to make a point that you realize, for you to realize how special this event is. You go into the I've never been to a surgical theater before I went to theirs. But one thing is clearly extremely special, that the professions that you see in the OR are not divided by gender lines. It's amazing. So first of all, the senior surgeon happens to be female, in case you haven't noticed. Okay, you rarely see such things in any OR in neurosurgery. It's very unusual. And secondly, if you look at the nurses and all the assistive staff, you find quite a few males there. So if you try to predict the occupation of the person by gender, and as is typically the case in Düsseldorf at least, you fail. And this is amazing, I think.
Yeah. Could open up a very, very, very tough gender discussion now regarding the number of female brain tumor surgeons in Germany. Actually, Marion is one of the leading persons in Germany to confront this problem, because of course still, as you can imagine, the number of female brain tumor surgeons is much lower than the male one population. But that is a different thing. The point that I did want to make here is that if you want to become a brain tumor surgeon, or if you want to take up responsibility and you are technically prepared, you need to take the last step, and she didn't do that. She was not prepared. And I can tell you, because I taught at least for 10 years or something like that, Mario. And she was completely different. I would not have been near the knife in this situation. She already would have opened the skull. So it's all about mentality. It's all about mentality.
So be careful.
But that is also true for for other challenging situations. So make up your mind, prepare yourself. If we are technically okay, then take the knife. This is very general advice, I know, but this is very, very beautifully demonstrated. And she rolled her eyes because I told her to do finally start surgery. Now this is a skin incision. Of course, always bleeding a little, and to prevent the bleeding, to stop the bleeding, we put in clamps, which shut down the vessels and attach the steroid drape. So if I worked, this would be real time. This hurts a little slower. Bipolar coagulation, if necessary. Sorry. I think that's boring. Okay, here we touch again Pterion to know where we are. We split the muscle, and then again orientation to the Pterion. We are right, navigation. Then we use a drill. This is a drill which stops when he has perforated the bone and is touching the soft dura mater, because it's coupling out, so it's stopping almost all the times, at least. And then we have a saw which has a small hook so that we can put it between the dura and the bone, and then we do the craniotomy.
I have to tell you an impression of an outsider. There are two dimensions here which are missing, which to me make this particular part difficult. One is the noise. So this, the noise of some kind of an electrical saw sawing into a bone is not pleasant. And the most important dimension in this part of the operation is the smell. To me, it's very difficult. This particular part, because the smell of burnt bone is not easy to digest.
No. Especially if you go, what I got rid of, because I can't stand this, at least my Hans Marion is still using it for the posterior fossa, is a monopolar coagulation. If you have a monopolar, it's a bone knife, it's called. It's really coagulating and burning the muscle. So we stop that and just take a knife. But if you do this in the summertime, you will not go to a barbecue. You will not do it. Or you will get very hungry, depends. So the bone flap is now, as we call it, craniotomy, and then we break out the bone, take out the bone. There's also a very nice noise. And here we have the problem that the dura is completely attached to the bone, so when we remove the bone, we see the whole brain, the exposed brain. Normally you see the dura. So now we do coagulation. There's always some specific part where the blood comes from. Then we use the ultrasound, and then we go into the brain and try to find the tumor. Sorry, that was too fast. And you see how helpful 5LA technology gets, because we identify the tumor. We take a small sample to send it to the frozen section. And then we work on the pia mater because this is a natural border, and we do the resection.
Just imagine how many things can go wrong so far.
So sometimes you see I'm very aggressive, sometimes I'm quite delicate. So here I'm very, very delicate because I do not want to perforate into the through the pia mater because there are the vessels. We have the vessel problem there that I told you about. And then I speed up and eventually this is one of the vessels that I didn't want to expose, but I did that. And you see that it's very near to the tumor. So if I would have ruptured that vessel, the patient would have an infarction of major parts of the right hemisphere, resulting in hemiparesis.
How dangerous is the bleeding?
The bleeding?
On the brain tissue, how dangerous is it?
The bleeding of the brain tissue?
On the brain. Like what we see in the picture now. Before we saw the blood flowing on.
It's looking more than it is actually. So the normal blood loss during brain tumor surgery, if you don't cut a huge vessel, it's 200 milliliters.
Yeah.
It's also very few, so it's not.
And this is under the microscope, it's 2 times, 3 times larger than in real life. So the blood that you see there is negligible. So it's
But I would suspect it gets diluted with the saline that they keep watering it with saline, and it gets diluted all the time. But maybe the camera doesn't see that. You know, so there's a lot of fluid there, but it's mostly saline.
So that's the removal of the brain tumor. You see that I'm quite rough here because I know that the functionality of the surrounding tissue is, well, you don't have to take too much care about that for reasons that we explain later on. So bipolar coagulation, and I think that that is a major message that you wanted to make, that 5-LA is helpful, that you find the tumor with landmarks. And now I was under the impression that the tumor is removed, and you see this alpha-5-ALA signal, protoporphyrin 9 signal to be exact, is still there, but it's not as intense as it has been in the brain tumor itself. So this is the infiltration zone, and there is functionality in it. Now I have to make the decision: do I leave it behind, which would cause an earlier recurrence, or do I remove it? And as I'm in the right frontal lobe, where we can't detect real functions if we don't do really neuropsychological facts, and the patient will receive radiation therapy of this area anyway because it's a very high malignant tumor, I can remove the tissue.
I just want to point out we don't have that much time.
We're ready. It's finished.
Okay.
We're finished.
Because, you know,
So we're finished?
sorry for being such a police.
No. That's okay. So closure, replacement of the bone flap, and that's it.
30 minutes in and out.
Sorry?
So you complete the entire surgery in 30 minutes.
Yeah, well, actually, how long does a surgery take? If it's not an awake surgery, if it's just a normal small tumor not lying in an eloquent region, you're right. The surgery takes about maximum hour. Yes, we're done. So we're going to the practical part. Just two more words, maybe. Soll ich das skippen?
Sorry?
Soll ich das skippen? Jetzt kommt ja adjuvante Therapie.
Yeah, just few words.
Nee, das funktioniert nicht. No,
It's still not going. No, that's too bad.
So maybe. So my computer is not working anymore. So the last point would be what about adjuvant therapy? As we told you, we're getting more and more aggressive, but still residual tumor cells are left behind, independent from the post-operative MRI. So even if it's perfect MRI, we know that there's tumor tissue, tumor cells behind. So we have to discuss adjuvant therapy. And I just showed you this algorithm now with this new neuropathological classification, how we get to know now Is it a glioblastoma because it's an IDH wild-type tumor? How is the tumor reacting regarding chemotherapy, radiotherapy? And based on that algorithm, we got now algorithm for treatment schemes. So if it's a glioblastoma, they get radiotherapy and chemotherapy combined, followed by chemotherapy. If they get special methylation stuff in the tumor, they get 2 times chemotherapy. And basically it's all based after surgery. So surgery is the first big step, and then we got
so this is quite an impressive picture. You see that it's very nice resection, and without any kind of radiation therapy and chemotherapy, you see that in a couple of weeks. It is very extreme, but normally you can't just rely on surgery, and that is what Marion made the point of. Surgery, radiation therapy, and chemotherapy need to be combined, and that depends on the exact localization of this patient in this algorithm. Okay, so for the sake of time, we just want to mention it, that surgery is not enough. Yeah? We have to think of other dimensions as well. Now, what we do now is we have 2 brains prepared, and the thing that we want to demonstrate is that how the brain feels and how 5LA looks like in